Well, I think you can probably see from Jack's comments that what may seem like a simple problem, what has credentialing got to do with quality anyhow, that it's an extremely complex problem that the standing committee has really been trying to get our heads around. And if you haven't seen the paper that Jack and colleagues put together. It's posted on the IOM website, and I believe it's also in your folders. So this captures a lot of what Jack was able to talk about. So now we want to do some Q&A. We have about 20 minutes for that. So let me turn first to our committee. Please. Joanne, go ahead. And could you please introduce yourself?
Sure. I'm Joanne Spriggs. I'm at the University of California, San Francisco, and a member of the planning committee for this workshop as well as the standing committee. So years ago, actually Dr. Bolton and I served together on the National Commission for VA Nursing. And there was a lot of discussion about the standards for magnet accreditation and credentialing in general and the qualifications of the nursing workforce to meet veterans' needs. The commission at that point stopped short of recommending magnet certification for all VA hospitals, but did recommend that the attributes of magnetism be pursued by the VA nationally speaking. So I've been pondering for, since then, of course, where the value add is of the standards or the attributes associated with credentialing, either at the individual level or the organizational level, versus the attainment of the credential in and of itself. And three reasons that I've been able to come up with, and I'd like to ask you if you have others, for arguing that the credential itself is valuable, would be transparency. That if you can say, oh yes, we of course try to follow the credentialing standards of a whatever nursing organization, but if you don't actually have the credential, how do we know you really do that? The enforceability, which would be related to that, and the monitoring. And then also, at least from the individual standpoint, there's the human resources management perspective, that if you as a human resources manager want to push your workforce into a particular direction, credentialing becomes a very clear signal for that kind of management process, which might be easier to deal with than a lot of other strategies. What are other reasons that the actual attainment of the credential might have that additional value?
It's a great question. I think the three rationales for the credential, for requiring the credential, looking for the credential, makes sense. The incentive effect. One of the challenges here, as I said, do we want just the attributes of magnet, or do we want magnet? The credentialing process potentially provides a framework for identifying the standards and a framework for moving people towards achieving those standards. So that represents the additional potential, to me, an additional potential value. When we were looking at the literature on magnet, there's the discussion of the magnet journey itself as having, as being value added over achieving the standards, or having even started as meeting most of the standards for magnet. So the question is whether, and if I were, one of the issues for research is whether you want to measure the value of the journey as well as the endpoint. And I think that becomes a question. And the same thing I think holds true for the individual credential. Is it particularly for the credentials that are more than minimal and required, the ones that are voluntary, where often there's an experience component. You have to have a certain number of years of work in order to even apply for the credential. You need to think about what the person who has that experience, who's been potentially studying the topic on which they're going to get the credential, what the journey towards the formal credential process adds to their knowledge, their self-confidence, their ability to articulate what they know and understand. So those, I think, are some of the challenges.
Linda, could you stand and introduce yourself? We're filming, so we want to.
Linda Burns Bolton, Cedars-Sinai Medical Center, a member of the Planning Committee. I have several thoughts, Jack. My first, though, is this whole notion of it not being just the individual who has the credentials, but whether or not there's an impact of a team of nurses who have the credentials. And when I look at some of the research that came out of dedicated units, dedicated education units, where you have a high number of individuals who are certified, and perhaps beginning to look at some of that as a part of trying to understand these pathways. Another example is where it's not just the nurses who also have the credentials, but if you look at acute rehab units, where you have the occupational therapists, the physical therapists, everyone is credentialed, and examining that as a forum to compare to see it's not just an individual, but how the team works. Could you comment on that?
Certainly. I think there are, when we looked and thought about, those of us who were working on the frameworks paper looked and thought about this issue, we realized a couple things. So from my perspective, an awful lot of our head model of nursing in hospitals is a primary care model, where it's one nurse, one patient. So we tend to think about how that nurse deals with that patient. But increasingly, there's a recognition that we've got teams of people, clinical teams, not only the nurse and the physician and the respiratory therapist and so forth, all working together for a given patient. But the unit staff organizes itself. So the charge nurse, knowing that mostly she's, have some credentialed nurses in area A, and some who are uncredentialed may be making assignments of patients based upon whether a nurse is particularly well qualified to deal with a patient with a particular problem. Potential skin breakdown, dementia, what have you. And that's a team organization issue. And if you ignore that in terms of researching patient outcomes, you can often wind up with the wrong conclusion. Like the fact that, the patients who are at higher risk for falls, with a fall expert assigned to them, may be at lower risk of falls than otherwise, but may still have higher fall rates, because that's why we assign them. So you do the simple, naive comparison of nurses with falls expertise against those who don't, and they have patients with higher fall rates. If you ignore the team organization of that work and the decision to assign certain patients to those nurses, you wind up losing it. A third dimension is the opportunity for informal or formal consultation and unit-based education, where the nurses who have the expertise are called upon to share it with folks, or either in an informal basis, I got a patient, would you come help me figure out what I need to be doing here, or more formal in-service training during the unit activities. So all those get missed if you only think of it as what does this individual nurse's credential do for the patients that individual nurse serves.
From our standing committee, questions? Questions from our sponsors? All right, let me go to our audience. So I'm going to begin your question. If it's yours, if you could rise and introduce yourself, and then I'll read your question. So we actually had another one on interprofessional. It's a little bit different, so let me read it and see if Jack has some additional comments. This starts with, as care becomes more interprofessional, should we move to credentialing groups of interprofessional teams, a category between individual and organizational credentials? Whose question is that? Could you please introduce yourself?
I thought I would be anonymous. I retract that question. No, I'm just kidding. I'm Leanna Orsolini, and I work for Bon Secours Health System in our corporate office on our APRN, Advanced Practice Registered Nursing Alliance, and moving us to, use our APRNs to the fullest amount of their education and training. We've got a couple magnet hospitals, some pathways to excellent hospitals, and I'm on the IOM Global Forum on interprofessional. Well, we work on interprofessional education and practice. So I'm just thinking we need a new category, like Linda Burns-Bolton said, of credentialing between the individual and the organizational.
Don't be that's a terrific question. It really is, and one that the folks who were authoring the perspectives paper spent a lot of time discussing, and probably did not provide anywhere near the amount of commentary and discussion that should have of that topic that should have been in the paper. It's one that deserves substantial reflection. Let me take a very rough analogy. My brother's a radiologist, and he does a lot of vascular radiology, and he's on the organization that credentials vascular labs, vascular radiology labs. And when they're looking at the performance of the lab, it's not just who the radiologists are or who the technicians are or what the equipment is. They're looking at the ability of that lab to perform. And we've got distinct groups like that within the hospital or within an outpatient area. I think the experience there suggests it's possible to think about a credential for an activity or a subunit. And I absolutely believe that as care becomes more specialized, there's a real value in being able to credential at that kind of unit organizational level. Where we're going to have more challenges doing that. But I think it's very important, and why we emphasize the organization of care as one of the intervening variables, but where we struggle to think about how to do it in terms of defining the organizational units, the subunits, is that it's hard to do that when you've got teams that are constantly morphing, right? And often morphing around individual patients. You got a med-surg unit, but you got a patient who is at risk of skin breakdown. I don't know why I keep coming back to that, but or at risk of falls, and the team, or at risk of delirium. And in essence, you've got the team on the unit trying to think about how do we keep this patient safe. But that team is going to look a little bit different this week than next week. It's going to look a little bit different for Mrs. Jones than Mr. Smith, even though Mr. Jones and Mrs. Smith are both on the same unit at the same time. So we need to think about, I absolutely think it's critical to think about the way work gets organized. And it's important to think about teamwork. So the question is, when do you have a stable enough team that you can accredit a team or assess the ability of this subgroup within the organization, the ability to deliver care? And when do you have these floating crap games of teams? That's a terrible metaphor. When do you have these ad hoc groups of folks with different levels of expertise, some different clinical training, other kinds of training, different levels of credentials, coming together to deal with patients? And how do we measure that? And right now, the data systems make it very hard to do that. I've seen one of the big EHR vendors, big nursing units, is beginning to try to get from HR people go back into the HR records and get information about each of the nurses on a staff in terms of their individual credentialing levels. And some of these systems are then telling you that in a primary care nursing environment, that nurse was assigned to this patient, and a nurse without that credential was assigned to this other patient. So we may be able to deal with the individual credentialing thing. But if the unit is organized itself as in thinking of itself as a team in dealing with those issues, then simply looking at the individual matching of nurses to patients is not going to be sufficient to understand the way care is organized and the way the organization performs. So we're going to need to think about ways to measure the way the teams serving patients are put together and how those teams perform. And if we can figure out how to do that, then we may be able to figure out ways to think about formal credentialing of teams within larger organizations that reflect our knowledge of which kinds of teams with what kinds of expertise and what kinds of communication patterns perform better.
Okay, the next one does have to do with the data sets. It begins, so as I read it, if it's you, please stand. You mentioned that we do not have data sets available. What are the minimum? I figured it was probably you. Could you please introduce yourself?
My question revolves around the comments.
Could you introduce yourself, please?
Oh, sure. I apologize. My name is Roy Simpson. I'm Vice President of Nursing for Cerner Corporation, and I'm an industry representative to look at the electronic health records. I'm also faculty at Emory University. My question comes in about data sets and the relationship of data sets that they're not there for the credentialing research. And so my question is, what in industry data elements are you looking for, and where do those come from out of research that we can move that forward so that they would be available for the researcher? Because we clearly have them. We're just not sure which ones you want. I mean, I'm familiar with all the staffing alignments. I'm familiar with all the EHRs. I know my competitive landscape pretty well. So I'm trying to make sure that we put those in, because we're putting white papers together right now about data sets, and it would be very helpful to know how we should go about this.
I'm going to kick most of that question. Ask that question again to the data panel. Seriously, ask that question again to the data panel. But just a couple of quick thoughts and reflections on that from our perspective. At a bare minimum, we need to know what the credentials look like, not just the high level required credentials like RNs, LPNs. We've gotten that out of standard data sets. We know that when people have tried to do work on baccalaureate prepared nurses, they've had to do special data collection. If we want to know the density of the nurses who have credentials in, again, skin care, delirium, emergency, and on and on and on, that's all going deep into the EHR databases in a lot of places. The ability to have that readily accessible and the ability to compare across different organizations will be critical to moving the first research agenda, the next research agenda forward, of just measuring what proportions of staff do, much as we've had some research on the proportions of staff that are baccalaureate prepared. So that's the first step. The next step is being able to get information on which nurses are assigned to which patients and have enough data at the patient level to understand individual outcomes associated with credentialing. And then the third is really this challenge that we just heard, to think about, get information about the organization at the unit level for dealing with specific patient outcomes or patient risk, and measuring the team organization. And that I would put as the second or even third generation of data, but one that we need to start thinking about right now. That if we're serious that we're talking about how to make teams more effective in delivering care, we have to be able to measure teamness. And we're nowhere near where we need to be in thinking about how to define those teams, much less measure whether they exist, and then how well they perform, and how the differences in team performance, the nature of differences in team performance across units and across hospitals.
So we're pretty much out of time, but I wanted to just let you know what the other interests are from the audience. Those of you who ask these questions, I'll read them. Hang on to them. There's a couple of ways we can address these. One is in further discussion today, there may be an opportunity that either answers your question or you'll have an opportunity to bring it up again. Also, in the breakout groups, some of these questions align very well with the breakout groups. So let me just tell you what's on your mind, and we'll carry this through. And they do relate a lot to what you've been talking about, Jack. So one is, and this is a very big question, we could have a whole IOM committee on this, which is, what is the state of research on credentialing of other healthcare providers, i.e. respiratory therapists, physicians? Our committee did consider other professions when we were looking at credentialing, and it's possible that you could bring that up in our breakout sessions, because there is a lot of things to learn from that. Another question had to do with the idea about credentialing teams. The question was, well, maybe we should be credentialing teams rather than places because people move around, and in the future, we're not sure how systems will look. Really excellent question. And then the final one was, and maybe you want to make a brief comment on this one. Have you looked at other industries regarding certification and credentialing, such as aviation, nuclear power, et cetera? Excellent question. Comments on that last one?
We looked a little bit, and we've had the benefit of some public presentations to the credentialing committee on other industries. And I think the real challenge in thinking about that is not only what you learn about the credentialing in those other settings, but thinking about both the similarities and the differences in the nature of the work in those settings to figure out what transfers easily and what is hard to transfer from the experience in other settings. We've already seen, for example, crew resource management techniques from aviation being applied to changing communication patterns in healthcare. That's a very creative use, but it's not a simple one-for-one translation. There's a lot of adaptation that needs to go on. I think that's going to be one of the challenges of thinking about what we can learn from credentialing in other settings.
Thank you, Jack. So we have a break now, 15 minutes. We'll gather back here about 5 after.